I'm just going to maximize my screen. Thank you very much again. Thanks very much indeed. Just like Christina said, it's an absolute not just pleasure but honor to be here today. Can you hear me?
Yes.
Great, fantastic. It's an absolute honor to be here today to just share my thoughts about glaucoma screening, and thank you very much indeed for having me. It's lovely to see some faces that I haven't seen since exactly a year ago, just pre-COVID, when I was in Abuja for the WAX conference. Glaucoma screening is what I'll be talking about today, thinking about the challenges it provides, the opportunities we may have to overcome those challenges. And I'm sure glaucoma, just like diabetes, and cataract is a very important aspect of ophthalmology, particularly in West Africa and Nigeria, worldwide. So, as one would do in many of these kind of talks, I'll have to declare my interests. Well, I am an ophthalmologist, but I'm not an epidemiologist. And in all honesty, this talk is at the edge of my comfort zone because it's actually more about public health and screening. Because my comfort zone lies in myopia control, glaucoma, cataract, laser refractive surgery. I highlight myopia control there, and I'll talk about that right now before I go any further forward. An interesting aspect of glaucoma, so I'm just going to say that and leave it. As we know, glaucoma and myopia, sometimes you just can't tell the difference between the two when they cause field defect. The challenge we're now faced with actually is that myopia is increasing rapidly. As if you've been sort of around and aware, there's been a twofold increase in the prevalence of myopia in Europe. Sorry?
Sorry, we can't see your slides.
Oh, okay. Which new share? Which screen am I sharing?
Nothing at the moment.
Are you? Oh,
yes, it's okay now.
Okay, so sorry about that. Okay, so yeah, there's been a twofold increase, and what's really curious about what's happening in Africans is that there's a fourfold increase in prevalence of myopia in Africans who are outside Africa, particularly those in Europe and in the Far East. And we know that myopia control and myopia progression is as a result of the modern lifestyles we live in closed areas. And that, for me, makes the interesting glaucoma screening even more pertinent, because if just as diabetes is transported from Europe and the Western world to Nigeria because of the way our diets and urbanization, if in addition to our burden of glaucoma, we get progressive myopia, then we will really have quite a significant problem with, as far as we know, irreversible sight loss. Right now, progressive myopia is the biggest cause of irreversible sight loss in Japan in people who are still in their active working lives. So we do need to get over glaucoma screening and glaucoma management early before the tsunami of myopia comes our way. So I am inspired, just like most of you, by my patients. And that's the other reason that I chose to talk about this topic that's really not within my comfort zone. In the past year, I've had to take care of 4 young, sort of under 45 Afro-Caribbean patients who presented blind in one eye and with aggressive disease in the second eye. Now, that may not be unusual for you, but it's very unusual for me here because the majority of my patients don't present that advanced, particularly when they're under 40. This would happen to Caucasians who are perhaps over 65. But when it comes to Africans and Afro-Caribbeans, this is happening when they're under 45. And this obviously shows a failure of our current screening effort, because almost all screening effort, and if you read most papers talk about their statistics over the age of 40. Now, why do we just talk about glaucoma over the age of 40? This has been predetermined by what happens here in Europe. Most people don't get glaucoma till they're in their mid to late 40s because they don't have as much glaucoma or as bad glaucoma as we have. And coupled with that, most case finding in glaucoma is when you visit your optometrist for the first time to get your first pair of reading glasses. And at that time, somebody checks your pressure here. They don't just prescribe glasses. Well, 30 years ago, they just prescribed glasses, no different from what would happen in most other sort of places. But now they're paid to do a little extra. So you will always get, almost always, at least in the past 10 years, get a pressure check. So we hardly ever get late presentation. That's why I highlighted my 4 young males. And that's because they don't get screened under 40. And the final part of my talk will be a very small touch on technology and how we should consider our roles in leapfrogging this late presentation that many of our patients, particularly of the Afro-Caribbean community, present with, and at least bring them up to what other communities present with glaucoma. Sorry. That was slow and then it's run. So a few definitions. We already know that glaucoma is a progressive optic neuropathy, which has some risk factors for progression, and it's associated with high pressure. So the definition of glaucoma is not high pressure. There is a high pressure association. The definition is a progressive optic neuropathy. So if we're looking for a problem and we only have 2 questions to answer, which is optic nerve and visual fields, then maybe we shouldn't be paying that much attention to pressures. Unfortunately, over 40% of damage happens before patients develop symptoms. Even before we're able to pick up visual field defects, over 40% damage has happened to your neurons, just in the same way as Christina talked about sort of retinopathy, increase in capillary micro ischemia. And obviously untreated, it results in blindness in a proportion of patients, thankfully not all, because we always have to keep glaucoma really in perspective. Thankfully, not all our patients go blind, but up to 20% would if we don't treat them, and a lot fewer would if we treat them. And the definition of screening. Screening is a public health service. The purpose of screening is to offer a test to people in a defined population, a defined at-risk population. And this defined population of people don't necessarily perceive that they are at risk of the condition or that they're already affected by the condition or its complications. So it's very important that before you consider screening, it should be an important public health problem. You should be able to have tools or systems or investigations with which you can recognize latent or very early symptomatic stage of the disease. So screening doesn't work if you're picking late disease. And we need to have adequate understanding of the natural history of the disease from the latent stage to late stage. And of course, there's got to be acceptable and successful treatment, because there's no point screening for a condition if you're not able to treat it. Don't know why this is refusing to move forward. Okay, next. Right, so the big question. Do we have a national screening program for glaucoma in the UK? I'd ask you to sort of guess your own answers. The answer is no. The National Screening Committee decided in 2019, and I think it will be reviewed in about 10 years, that the sensitivity and specificity scores of available tests are not acceptable for use in glaucoma screening. And also there have been no randomized controlled trial to show that screening reduces morbidity. And when I first read that, I was very confused. So what we call screening actually is only opportunistic detection, which in this country is mostly, in the UK, is mostly carried out by optometrists. The reason there's no national screening program is because of the complexity of glaucoma. There are multiple and varied risk factors for glaucoma. And perhaps with the Human Genome Project, we may start to map things better, and we may be able to have a better understanding of our risk factors. But till then, that we have no clear way of identifying which people are going to get glaucoma prior to them getting the disease. And there's no single simple screening test, because we know that some people with high pressures don't have glaucoma, at least don't have glaucoma yet, perhaps because of their corneal thickness. They may never get glaucoma. And we also know that there's this significant group of people who have a progressive optic neuropathy with visual field loss, but normal intraocular pressures. And disc assessment is not regarded as a screening test, because as at the time this was looked into, all the evidence actually was based on disc photography. And it's not really been looked into just as well with modern technology of disc imaging. And also it's got to be, because disc imaging is relatively less invasive now than it used to be, but the previous versions were just not good enough. As we all know with visual field testing, if you've ever tested yourself from day to day, visual field testing can be a bit, it depends on how you feel on the day, and our patients have significant variability. So to explain it further, to be able to do anything with screening, an ideal screening program should be able to pick out just the people affected by the condition, and should be able to not pick out, it should be specific enough not to accidentally pick out people who are not going to be affected by the condition. And there are other things we don't know. There's some people, as I've said, who have ocular hypertension who are never going to develop glaucoma, and some people have normal pressures, but they have discs and fields like that. The great thing is, not all people with glaucoma go blind. So what we need to do is identify which ones are likely to have to go blind, and that's what the aim of our sort of follow-up and treatment is. So conventional case finding here in the UK is mostly by optometrists, and most of the time, actually, their effort is funded by selling glass spectacles, because if you think of it, they get between 16 and 22 pounds from the government if they do the GOC forms for children. That doesn't pay their sort of £50 an hour sort of locum rates. So in most optometry shops, there is always a push to sell spectacles. And I always say to my optometry friends here that it would be great if you charged for chair time, because then you'll be able to do a lot more of what you're qualified to do, because optometrists here are very highly qualified, and now they're doing many more courses, to sort of advanced courses in glaucoma screening, advanced courses in infection treatment, and those type of things. Yet they just, most of what they do is funded by selling glasses. Other places where glaucoma is picked up, of course, is hospital glaucoma clinics, as well as community hospital. There've been a few attempts at mobile units, but that never took off in the same way as diabetic retinopathy screening took off in mobile units. And of course, there's some remote clinics or diagnostic hubs. Interestingly, just 2nd of February this year, 2nd of February last month, Moorfields opened its first diagnostic hub, where basically the patients go just to have their tests and they leave. They don't see any doctor. Everything is remotely sent to doctors. This model has been well tested by New Medica and other smaller organizations for several years. So Moorfield's just coming behind them, really. And then the patient then gets a call to assure them that everything's been fine, or to tell them that you now need to either move on to the next stage of being seen regularly in hospital, or you need to return again in a year. Just a little bit like the diabetic retinopathy screening program. And then when I was at the academy in 2016, I saw this very sleek sort of device or contraption, which is a very convenient way for case finding. And as things happen in America, what happens is you arrive up in the shopping mall. These things are kept in, the idea here is that you keep these in a shopping mall or in a general practice, a GP's practice, or in Nigeria, it could go into a chemist or into a medical practice where there isn't an ophthalmologist. It's generally not aimed at an ophthalmology practice for use. It's aimed at ophthalmologists as a referral source. So you have this device in which I sat at that and took some pictures myself, but I couldn't find them. So you sit there and you put your chin on the rest and you do your visual field. So no, this is America. You register here first, you put your Visa card there and pay first of all, yeah. So once you've paid, so it's all, you don't need anybody. You're right in the middle of the mall and you can operate this all yourself. You get instructions on what to do. And inside this globe are 4 different pieces of equipment. There's a retinal camera. There's something like an ocular response analyzer or an air puff tonometer. There are a couple of cameras, a digital disc camera and an OCT. So you sit there, you put your chin rest on there and you just follow the instructions and all your tests get done and you go home. And then you then get a letter or a telephone call to tell you, thanks for using GlobeCheck, your test went well, please visit us again in a year to repeat it at one of our locations, or things didn't go well, please come to my clinic and we'll arrange to do some further tests, which will include the gold standard tests. So that's very interesting. However, I've already talked about this actually. Yeah, however, we've talked about the funding structure in the UK, the potential funding structure in the States for case finding, as well as the traditional case finding methods. But we also know, which is what happened to my patients, I'm going to keep coming back to my patients because they're my inspiration for this, that there is a low ratio of eye care professionals to the population in relatively deprived communities or people who can't pay for eye globe themselves. Okay. Right. And we also know that there is obviously greater risk of sight loss when you're older, and you may not necessarily be able to attend these case finding opportunistic events. If you've got a positive family history, at least here in the UK, if you've got a positive family history, you are allowed to go for a free glaucoma check from the age of 40. If you're of African origin, if you've got myopia, if you're diabetic, or if you have other peripheral vascular disease. Now, like I said, the challenge with conventional case finding is that sometimes our patients avoid going to the optometrist because they fear being pressure sold a pair of glass spectacles for £600. And we now have available online and over-the-counter readers. So when you're 45 and over, when you get presbyopia, you no longer need to seek to go to an optometrist. If you used to be a metropic, you just go online and buy your pair of +2s, or go to Boots and buy your pair of +2s. So there's that lost opportunity to get your pressures checked. we're still in the developing world. Let's go out of the UK now, and this includes Nigeria. There's poor funding for healthcare. We have poor infrastructure, so we don't have the internet. We don't have telephony. We don't have sort of great hospitals for in every region that's accessible to all our patients in the rural areas. And there's a significant problem with the ratio of eye care professionals to patients. So this is number of eye care professionals per million to patients, ophthalmologists, but I know it's the same for, it's very similar statistics for optometrists, except perhaps in Benin and a few places where they have optical optometry degrees. And I mean, if you think of that, 3, and the UK is not doing great because in Greece, they've got 178 ophthalmologists per million, but in most Western countries, they've got France, Croatia, they've got about 100 per million. But that's ophthalmologists. But where UK is different is that we probably have the highest ratio of optometrists per million. So that more than makes up for what we lose on the ophthalmology end of things. But what's even more bothersome is the fact that we have twice the prevalence of glaucoma than the UK. So just multiply the risk, is quite massive. Here we feel that 50% of our glaucomas are undiagnosed as against 90%. So this is quite a major problem. And add to that, but I could find no statistics on this, perhaps Dr. Chiari would know, is the fact that most of the studies talk about prevalence over the age of 40. Prevalence here under the age of 40, if you've not been picked up as juvenile glaucoma, is quite low. But in my experience as an ophthalmologist, even in the UK, prevalence of glaucoma under the age of 40 in Africans, particularly Afro-Caribbeans, people from Barbados who apparently originate mostly from Igbo land, is quite high. And we're not checking them, we're not screening them, we're not actively case finding in that group. Okay. And yeah, we've already done that. So what's very interesting, as I said, is that we also have reduced CCT, which increases our rate of false sort of non-normal tension glaucoma diagnoses until we started to do central corneal thickness as standard. So I would like to sort of greatly advocate that if you don't have a pachymetry already, that please get yourself one. And an additional challenge we have specific to the African population is that we tend to have poorly managed comorbidity. So not only do we have those things, because we're now beginning to get a lot of these Western diseases, whether we're here or there, because even 30 years ago, all these diseases were not as rampant in African communities when we just ate our own high fiber diets as they are now when we've all sort of transitioned into eating purely Western diets. We exercise less. We're no longer running after the buses. We now have our own Mercedes-Benzes. We're sitting in the cars. And even when we're hypertensive and we have the GP to see us, we have poorly controlled hypertension, or we go the other way and have nocturnal hypertension, which are all risk factors for progressive myopia. Now, there are a couple, yeah, and when I read the Barbados eye studies and I looked at Dr. Chiari's paper on prevalence of glaucoma, I was very interested to see that she felt, her group found that the Igbo people had a higher rate of prevalence, and interestingly, people from Barbados seem to originate mostly from around there, which was very interesting. Now, I've got a couple of sort of interesting slides. I'm not sure what the significance is, but again, in preparing this talk, you learn a lot when you learn to teach people. So I would highly recommend it, even though it could be a bit stressful. Africans have shallow orbits, like we probably all know, because cataract surgery and all that's easier in an African than it is in a typical male white, blue-eyed person with deep eyes and high brows. particularly African females, but I noticed that in some studies, African males seem to have more glaucoma. So this is a human female African-American, a male African-American and all that. And what you notice is that without even looking at this, Europeans have bigger eyebrows, bigger noses, yeah? Africans, we have much flatter eyebrow and much flatter noses. And what does that result in? If you happen to be one of those people who tend to sleep with your face down, the side of your eye that's closer to the bed, to the surface of your bed, actually has an increase in pressure of up to 4 millimeters, in addition to the fact that when we lie face down, this is actual measurements from spinal surgery, the pressure in the eye goes up to as high as 40 millimeters of mercury during prone spinal surgery, you know, when you lie down in those face, so those things that the couches with the face down. And some people have actually lost vision post-spinal surgery from just that position. So if you then add that to the fact that you don't have the protection of your brow and your nose, don't know if that has an added factor to the increase in problems with glaucoma in Africans. And I was very interested to see that there's a lot of talk about that in the area in which I looked for it, but somehow it hasn't translated into the regular literature. And I don't know if that's because of the difficulty with measuring those morphologies or if it's really not significant. So, quick recap. The challenge is that particularly in low socioeconomic communities here in the UK or in the third world, there's a high burden of disease with glaucoma, there's low resource, there's limited infrastructure, and of course there's the brain drain. My patients were my inspiration, and the aim is to look for how we can take care of them, reduce blindness in a convenient, affordable, cost-effective, and future-proof manner. And in order to do that, we need to be alert to our opportunities. Now, the old mainframe computer that sent the first 3 men to the moon in 1960, whatever, no, I was 4 or 5 years old then, 1967, thereabout. The power of the entire computer is not as large as what we all hold now in our mobile phones. So things have moved very rapidly from the 60s to the 80s and to now. And I think we have an opportunity here because things continue to move very rapidly with digital technology. They're becoming lower, whereas a whole country had to buy that. Now everybody here has one of these in their pockets, including most children on the streets of Lagos. So there might be an opportunity here for us to bypass, like we all remember when we all had to queue for telephones at the Nitel. Now nobody has to do that. We never had to get through the phase of wiring every home up before almost every Nigerian got a mobile phone. And why have I said that? Similarly, you've got this visual field equipment that have gotten smaller and smaller for screening, but that's still high cost. That's still about $4,000, whilst that's about $30,000. And case finding can happen if we continue to drive costs down and make use of our current technology. And the fantastic thing about the case finding thinking currently is that we don't need to look for pressure. We just need to look for something to check fields and check disk photography. And there, my daughter actually found this for me because she's doing computer science when I was preparing this Gear Vision smartphone-based head-mounted perimeter, because she happened to have one of those head-mounted things that she was doing her project with at home. And I said, this would be great for fields. And she said, it already exists. And here we are. And that's where we need to engage with the younger ones. That is still expensive, but that is fantastic because by people creating these expensive devices, other people modify them to make them affordable. So you can imagine you've got this Google Cardboard VR field testing device for which you just need to get this cardboard, you need to get your mobile phone, you need to get the app or software. You need to do your test, you need to upload it to your specialist, or you can, I'm sure with AI, it'll even tell you if you passed or not.
Bola.
And on the disk imaging end, sorry?
Stand up in 2 minutes, please.
2 minutes, okay. On the disk imaging end, we can go rapidly from this massive equipment to smaller and smaller equipment. And the only addition you need for your mobile phone to achieve disk imaging is just this little plastic device. And if you add that to remote telemedicine, artificial, this, by the way, is what you get with that gear, that's visual field compared to Humphreys. So that's been proven as a positive correlation. So with modern technology, we are able to defeat glaucoma. What we all need to consider doing is get some awareness of our local screening program wherever in the world we are. And depending on what the health economy is, we should inform ourselves of these low-tech screening possibilities. We should do some funding and advocacy, engage our youths, and we should try to seek means of case finding, provide training to the locals, and accept referrals. Thanks.
Excellent. Thank you.